So, hi, I'm so happy to have you here today. Anjali Sadhwani. I probably said your name wrong. I've known you for so long. I always called you Anjali. Dr. Sadhwani, please correct the way I say it when you
No, your
introduce
name is
yourself.
the articulations are appropriate. Thank you.
Okay. So I'm Dr. Terry Jo Bichell. I'm a neuroscientist. I have a 22-year-old son with Angelman syndrome. And I'm really excited to be bringing the Angelman updates to the community where we're hearing from all of the cutting edge researchers in the field to hear about what they're doing and get to know them a little bit. So this is brought to you by both FAST and ASF, the Foundation for Angelman Syndrome Therapeutics, and the Angelman Syndrome Foundation. And Dr. Sadhwani is one of those rare people who, well, not so rare anymore, but who is involved with both. So welcome today. And if you could introduce yourself a little bit.
Thank you, Thank you, Terry Jo. I'm Dr. Anjali Sadhwani. I'm a clinical psychologist at Boston Children's Hospital and an assistant professor at Harvard Medical School. I have a PhD in clinical psychology, and I graduated in 2008. I have been working with the Angelman community for over 10 years now. It was introduced to Dr. Vinhan Tan, and I joined his natural history study in 2010. And I've absolutely loved working with this community.
So we got you right when you graduated, basically 2 years after you were graduated, we got you brought in here. Go,
Yes.
Dr. Tan. That was a great move because you have really done so much. And I almost didn't know what to ask you about because there have been so many amazing projects. But could you just tell us a little bit about what you're working on right now for
Sure,
the
absolutely.
Angel?
So what I'm specifically working on, from 2006 to 2014, we had done the natural history study, and right now what we're doing is we are analyzing data from that study, and we are looking at key outcome measures which are going to be used in upcoming clinical trials, like such as the Bailey and the Vineland, to see without therapeutic intervention what is the natural history, how much change happens over time. And these data are going to serve as baseline data for the therapeutic trials from which they can assess whether change happens or not. In 2017, Dr. Tan got funding from the FDA to revamp and relaunch the natural history study. So so currently we are recruiting participants for that study. In that study, we continue to do developmental assessments, actually using more updated measures. So in the old study, we were using the Vineland 2 and Bailey 3, and currently we're using the Vineland 3 and Bailey 4, which are going to be used as outcome measures. And so we do a developmental assessment of the child using these measures. We also assess for other domains of development, which we didn't assess in our previous study. So we look at anxiety, which we know is a co-concern in our families. We also look at communication beyond just speech, right? We know that our families use a lot of AAC, they use manual sign, they use gestures. So we are assessing all the different ways they communicate using different, very well-validated measures, such as the communication matrix and the ORCAR. And we're hoping to analyze these data and to see how they change over time.
Okay, you just said a lot. So
Okay.
I'm going to pull it apart a little bit and see if I can explain all the different things that you just talked about, because it's really, really key what you're working on. So to restate what you said, that you have started a few years back with Dr. Tan, a revamp of the natural history study. And just for people who some people don't really quite get, why do we do natural history? They think, well, why would I study? Why would you study my kid if you're not giving him a medicine, if you're not giving him a drug? And I think that's one of the most important things that we can explain to people. So can you explain just a little bit, why would anyone bother to go and participate in just a study of nothing?
So the natural history study is really key. We know Angelman syndrome is a very rare genetic disorder, right? It's 1 in 15,000 in the population. What has happened in the past, people have been doing studies with small sample sizes, right? I've seen studies with 30 patients, 40 patients. Our natural history study, the old one, was the only one which was able to use a sample of 300 participants all across the US. And we were able to see how development changes over time. Like, we're able to see what are the issues in infancy, when do seizures occur, what happens when seizure medication is controlled. We also realize that as children change over time, their development changes and the different problems emerge at different areas of time. And so I think that's really important to capture what their development is and what are the parent concerns at different ages. We also specifically noticed that we don't have as much data about the adults, right? Genetic testing has just been very recent. So the adults who were diagnosed 20, 30 years ago, we don't have much data what their trajectory looks like. What are their issues? Does the ataxia increase? Does the scoliosis increase? So for us, the natural history gives us a very structured, standardized platform to look at all these individuals across all these ages and to see how does development happen? What are the key concerns at different ages? And how can we help support the family?
So when you're talking about my son, who's 22 and who actually went to do the natural history study this past week, I mean, what can you learn from him?
So I can learn, like, I think I've seen actually your son several times in person, right? So I can assess whether his development has changed. You know, AAC was introduced in the last 5 to 7 years only and has rapidly changed to see if he's able to communicate more with AAC devices. I've also noticed with adolescents and adults, there's an increasing piece of anxiety. And that's really important to assess. In addition, I think the motor, the gait, changes over time. It may have been possible that Lou was walking independently and doing more things when he was younger. And as he's gotten older, we notice that the motor changes a lot over time. We've noticed adults find it really hard. Their mobility becomes more and more limited. They're not walking as much. They need more support. And so those are the things that we want to look at.
Hmm. So you're everything you just said is absolutely true about Lou. His motor skills have changed over time, and I really want people to understand why. And so for me, that's a really important reason to be in the natural history trial for sure. But one of the other things you just said, you have people come in person, right? They actually have to go to the city and you see them in person, even during COVID?
So, no, during COVID, we had to revamp into just doing all our visits virtually. So, we were able to do interviews with parents virtually. We were able to collect information about the child's development and the medical history virtually. So, the good thing about COVID, it gave us access to this virtual platform, which we've now integrated. So, now what we're doing is we've moved to a more hybrid model where we try and do everything we can with the parent virtually. So we'll do all the developmental history, ask the questions, any interviews that we have, and then we'll bring the child or the individual in for a very brief 1 to 2 hour assessment where I would assess his development, and then the neurologist or the geneticist would look at his neurological skills, his motor skills, and do a more brief neuro exam. So I think that there has been a benefit of COVID that we've been able to revamp this to a more hybrid model, because we know that bringing your child to clinic is very, very stressful. So we want to minimize the time the child is in clinic, make it a pleasant experience for them, and try and do as much as we can with the parents at their own convenience.
So I completely respect that, because when first of all, COVID aside, most of the time for these visits, I'm the one answering most of the questions. So if you could do those questionnaires and those surveys on Zoom or on the phone, and I don't have to get childcare for anybody else, and I don't have to worry about Lou doing crazy stuff in the exam room, and I don't have to, worry about all those things. It makes it so much easier and less stressful. So first of all, that's even without COVID. Then when you add COVID into it, the last thing I wanted to do was take my son into a hospital
Right.
when he's healthy just for somebody to look at him. But for you to talk to me about him on Zoom, that's great. I love talking about him and having you ask questions and then be able to compare all those questions over his whole lifespan and with a lot of other kid grown-ups and kids with Angelman syndrome. I mean, it's really amazing. So that's very cool. So you have the hybrid model now. So some of it's done on Zoom as much as you possibly can, and then some of it's done in person. What if somebody can't come in person at all? Can they still do it, or do they
Right. So
have?
we recognize that families are still not comfortable coming in, and we absolutely respect that. Our study is going to go on for the next 2 or 3 years. We hope that at least in that we can start off definitely doing virtually, but we hope at some point that you would feel comfortable coming in person, because what's happened is just as COVID happened, we switched to a newer version of the Bailey 4. And the Bailey 4 is actually going to be used as a key outcome measure in all the upcoming clinical trials. However, because we don't have as many in-person assessments, we don't have as much data on the Bailey 4. And the Bailey 3 and the Bailey 4 actually work a little differently. So I think that's why we want more participants coming in person just to complete that Bailey 4 so we can get that data for the upcoming clinical trials.
So I remember a lot of people felt frustrated with the Bailey because they felt it was sort of for babies and they didn't like the tasks involved. Is there anything changed about it that makes it a little less babyish, or is it
Yeah.
still?
So we do hear the frustrations of the families, right? Like, this is my child is not interested, but my child is not motivated. We've gone back and forth with several experts in the field to figure out what's the one test that we can use across all the different ages for Angelman syndrome, right? We know some kids are doing much better, some kids are still struggling. And unfortunately, the Bailey has become the only test which the FDA approves as a measure to assess development for the Angelman population. But we've spent the last couple of years actually standardizing the Bailey across the things so people are doing it more consistently across sites. We've also included, as much as possible within the test limits, motivators that we could use for the child. We're trying to balance what we can get. We know that what we're seeing in clinic is just a snapshot, right? But we want to get the best possible snapshot of your child. And that's why we supplement the Bailey with more of an interview of his adaptive functioning, which we're using the Vineland. And that's why we ask you, what does Lou typically do at home, right? And those are skills that we want to. So we're always interested in correlating how the Bailey falls with the Vineland that we do. So we recognize its limitations, but we try to adapt it and then correlate it with more home-based measures.
So whenever people say adaptive functioning, I never really exactly understand what that means. Can you explain what that means?
Adaptive functioning is how he functions in his day-to-day life in different domains, right? So how is he communicating his need? What does he understand? What does he do in terms of self-care, right? Is he able to brush himself, brush his teeth? Is he able to bathe himself? Where is he in terms of toilet training? How is he socially with other kids? How is he able to navigate his environment? Can he go up and down stairs? Can he go over an obstacle? So adaptive functioning is the practical skills that the child is using in their day-to-day life and how they're able to do, because it gives us a sense of the level of burden and stresses on the family.
So I guess in a way it's different from IQ. So a lot of times people think of these tests as IQ tests, but what you're talking about is what can the child actually do for himself to help himself or as part of the family. That's what the adaptive functioning means.
Yes.
Cool. Okay, so what right now you have I think you've gotten a grant from, is it the A-bomb?
We had a grant from the ABOM to standardize the Bailey. So for that, we had gotten experts in the field as well as Bailey experts to help us to know what standardizations we could do. In addition, Dr. Ann Wheeler and I got a grant from the NIH. We recently got an RO3 grant to understand MCID, which is minimal clinical important differences in the Bailey and the Vineland in Angelman syndrome. So what we're trying to see here is, using all the data that we've collected, what's the least amount of change that we can expect in the Bailey and in the Vineland scores, at which point we can say a therapy is effective. And so that's why the natural history data is very important for that.
That's great. So basically what you're looking at is something like, if my son were able to tell me every time he needed to use the bathroom, even if he couldn't take himself to the toilet, would that be enough of a change that would help our lives and be worth taking the medicine? Something like that.
Right. For our example, if your child is able to walk with support, right, and with intervention, he's able to take 5 steps independently, we would consider that. So I think we're trying to find out what's the change, the minimum amount of change we need to be able to say a therapy is different. And we know that within the different subtypes, we would expect different changes. So I think that's what we're trying to look at our data to figure out what are the anchors we can use across subtypes to say that a therapy would be effective.
That's really a big deal, because I know that especially for the older individuals, that we might not see a giant dramatic change, but we might see a change that would still improve our lives, the child's life or the adult's life and the family. So it's a really big deal to figure out what the minimal improvement is. How long is this grant for? When will you tell us the answer?
I don't think it's a 2-year grant, and we just got funded of it. We just started to work on it. I think there's a lot of, as you said, I don't anticipate we have a clear-cut answer, but we'll get closer to the answer as possible, right? We know that there's a rate of change is different across different ages, right? We know that the younger kids develop faster, and the rate of change with older adults and adolescents is slower. We also know that differences across molecular subtype. So I think we're going to look at all these factors and figure out at this age with this molecular subtype, what kind of change do we need to see?
Wow, that's really, 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 really interesting. And I'm so happy that you got that grant and that you're going to be doing that. And truthfully, I think it's going to make a huge difference, because right now, well, actually, I wonder, right now, the way all the clinical trials are done, they have to compare to a placebo. And a lot of times it seems like the kids on placebo improve too.
Right.
And it's really hard to tell whether the kids on the placebo are improving because even just going in and doing testing is helping them learn, or if it's because they're developing the way they would have developed anyway. So if you could somehow be able to look at a little difference and say, okay, but even that little difference, even if it's this close to the placebo, could still be worth it to families, that would be great.
Yeah, no, I think that's what we're hoping to get. I think that's why we're looking at the old natural history data, looking at seeing what change happens on the Bailey. And I think we published that paper earlier this year, and we're going to look at what changes happen in the Vineland over time to see what's the minimum change, and then use that to base the anchors.
So did you ever think you were going to be doing work like this when you were studying, or what were you thinking you were going to do at that point?
So I think it was completely serendipity that got me into the Angelman world. I just finished my postdoc. I was specializing in early childhood education and doing developmental assessments from them. And then I met with Dr. Tan was looking for a psychologist. I met with him. He was looking for a psychologist to do genetic testing and rare developmental disorders. And I absolutely fell in love with the community. I realized that they are a very close-knit community, and I really, really loved working and getting to know the families in the New England area and all the families in the natural history study. The great thing is I get to see them over time. I've been seeing some of these families for the last 8 to 10 years, and it is fascinating to see how the resilience in the families, and also the therapeutic space change over time.
You mean all the different medications, well, that are
The
either
therapies,
about
the
to
ASOs,
happen
and
or
yes.
Mhm. So at this point, how many children with Angelman syndrome, people with Angelman syndrome, do you think you've met?
I've met, so I've personally assessed over 100, participants. I've definitely met more families at conferences, but I definitely have personally assessed 100 to 150 participants at least. I've never sat down and done a count, but I think definitely that many.
And most of them you've seen over time.
Yes.
That's pretty amazing. I wonder if there's anyone else in the world who's seen that many.
I don't know, but I'm sure other geneticists have seen more. But it's been really rewarding for me to follow these families over time.
Well, thank you so much for talking to us today. I really appreciate it. And I appreciate that you're doing this interview on a weekend. What would you be doing with your day if you weren't sitting here talking to me?
I would probably be going out and taking a walk. It's a beautiful day outside. It truly
Well,
has been my pleasure.
thank you so much. You know, I'm going to be the first person to read your paper when it comes out. I'm so excited about it. And I just don't stop. Keep up the good work. And I can't wait to talk to you again, maybe in 6 months or so, get an update.
Perfect. We definitely will do that. Thank you so much. It was a pleasure talking to you.
It was. Bye.
Bye.